Usually when we talk about staring deeply into someone's eyes, there is this expectation of romance.
Oh, yeah, like a whole movie scene.
Right. You're trying to read their emotions or look into their soul, the whole 9 yards.
It's a very poetic idea, honestly. Well, right up until you step into a clinical setting, then that romantic gaze gets entirely stripped of its poetry.
Completely, because
Yeah.
suddenly you're not looking for love, you're like looking for intracranial pressure.
Exactly. It's a whole different vibe.
Yeah, you are staring at this diagnostic landscape that is just highly mechanical, unforgiving, and honestly a little intimidating.
Oh, absolutely.
If you are prepping for the NCLEX right now, or maybe you're a working nurse looking for a clinical refresher, you know that ocular nursing can feel incredibly overwhelming.
Yeah, there are so many tiny, delicate structures.
Right, and highly specific screening metrics and just um, a mountain of bizarre-sounding terminology.
It can absolutely feel like having to learn a totally separate, highly specialized medical dialect just for one single organ.
Which is exactly why we are here. Our mission today for this deep dive is to distill that overwhelming world down into a condensed, high-yield, and, slightly quirky mental cheat sheet for you.
And we've got some great material for this.
We really do. To build this, we're pulling the best insights from an incredibly helpful clinical eye assessment episode of the Nursing Side Quest podcast.
Such a good breakdown in that one.
Yeah, and we are pairing that with a dense but super vital set of clinical eye notes that covers like the nitty-gritty screening intervals you really need to memorize.
So we basically have the conversational clinical application layered right over the hard data.
Right.
It's just the perfect foundation.
Okay, let's unpack this, because before we get into how to conduct a routine eye exam or the physics behind an eye chart, we first need to know what a true ocular emergency looks like.
Right, because the routine stuff can wait.
Exactly.
Yeah.
In nursing, you have to know when a symptom means you need to drop whatever you are doing and intervene immediately.
Context is everything in the clinical setting, and the biggest contextual clue you will ever have is time.
Time, yeah.
You always have to distinguish between gradual visual changes and, sudden visual changes.
So gradual change, that's like a slow burner.
Right.
A patient mentions their vision has gotten a little fuzzier over the last 6 months or something. That points us toward systemic chronic issues.
Exactly. Things like aging or uncontrolled diabetes slowly altering the tiny blood vessels in the retina over years, or even long-standing hypertension.
Right. Those are conditions that absolutely require a thorough workup and long-term management, but they aren't necessarily a, call the provider at 2 in the morning kind of situation.
No, definitely not. Sudden changes, on the other hand, are your massive red flags.
Drop everything.
Literally. If a patient experiences a rapid, sudden shift in their vision, you start thinking about acute catastrophic problems immediately.
Like severe head trauma or a dangerous spike in intracranial pressure.
Yes. And there are a couple of very specific textbook phrases you need to listen for here.
Oh, this is so important for the exams.
Yeah. The one that demands immediate action is the presentation for retinal detachment.
Right.
The classic description is a patient saying it looks like a shade coming down over their vision.
A shade coming down.
Or they suddenly see a massive cluster of cobwebs.
Wow, cobwebs.
Yeah. That is a severe medical emergency. And to understand why, you kind of have to look at the mechanics of the eye.
Break that down for us.
So the retina is this incredibly thin, delicate layer of light-sensitive tissue at the very back of the eye. And it relies entirely on the layer of blood vessels beneath it, the choroid for oxygen.
Okay, so it needs that blood supply to survive.
Exactly. In a detachment, the gel-like fluid inside the eye shrinks or shifts, physically pulling and tearing the retina away from that supportive blood supply.
Oh, wow. So it's physically ripping away?
Yes, the photoreceptors, the rods and cones, are literally suffocating. So if you hear curtain or shade coming down, you notify the provider immediately because time is tissue.
Time is tissue. I love that.
Yeah.
I always picture retinal detachment like a movie theater.
Oh, that's a good way to look at it.
Yeah, if the picture gets blurry over the course of a year, maybe the projector lens is just dirty light. That's a gradual change. But retinal detachment's shade coming down, that isn't a software glitch. It is the movie theater projector screen literally tearing and falling off the wall.
Oh, man.
The hardware is collapsing.
Okay. That is a terrifying but mechanically accurate analogy.
Right.
And another sudden hardware-level emergency is acute angle closure glaucoma.
Because regular glaucoma is usually a slow process, right?
Right, but this acute version is dramatic and violent.
The presentation is intense. We are looking at a severe headache, nausea and vomiting, extreme eye pain, redness, blurred vision, and the patient seeing distinct halos around lights.
Yeah, and it really comes down to plumbing. The eye constantly produces fluid that needs to drain out through a specific angle, like a microscopic filtration canal.
Okay.
In acute angle closure, the iris suddenly bows forward and physically blocks that drain.
Oh, so the drain is just entirely clogged.
Yep. The fluid keeps being produced, but it has nowhere to go, so the pressure inside the eyeball skyrockets in a matter of hours, basically crushing the optic nerve.
Wow. So again, not a schedule of follow-up for next week's situation.
Definitely not. Now, there's a nuance here with blind spots, which are mathematically known as scotomas.
Okay, so glaucomas.
A blind spot can mean two completely different emergencies depending on how it behaves.
Okay, what do you mean?
Well, if the blind spot is consistent, like it is just sitting in their vision and it never goes away, that points right back to the physical hardware collapsing. That's retinal detachment.
But if that blind spot is intermittent-like, flashing into their vision and then disappearing, you actually have to shift your focus away from the eyeball itself.
Exactly. An intermittent scotoma suggests the physical eye is fine, but the visual cortex in the brain is glitching.
Oh, wow.
Yeah, you're looking at a potential stroke, a traumatic brain injury, brain swelling, or, a lurking aneurysm.
Which actually brings up a distinction that initially tripped me up regarding double vision or diplopia.
Oh, diplopia is a tricky one.
Right. Sudden double vision in both eyes is flagged as a major brain emergency. But if a patient has double vision in just one eye, it's considered totally low stakes.
Yeah.
Why does covering one eye completely change the urgency of the diagnosis?
If we connect this to the bigger picture, it all comes down to the sheer computing power required for human vision.
Okay.
We have binocular vision. Our extraocular muscles have to keep both globes perfectly microscopically synced so that the brain can take two separate images and fuse them into one 3D image.
So it's an incredibly complex alignment system.
Exactly. The cranial nerves, specifically nerves 3, 4, and vi, are constantly firing to maintain that alignment.
Right.
If you have binocular diplopia double vision when both eyes are open, it means that complex neurological alignment system in the brain is failing.
Because the nerves aren't communicating properly.
Right, causing the eyes to drift out of sync. That's why it's a huge stroke or neuro red flag.
Wait, so if I'm understanding that right, having the patient close one eye essentially acts as a neurological troubleshooting step. You're basically isolating the hardware from the software.
Precisely. If they close one eye and the single open eye still sees double, which is monocular diplopia, it means the brain's binocular alignment system is perfectly fine.
Oh, that makes so much sense.
The issue is just a localized surface problem on that specific eyeball. Like most commonly, severe dry eyes or an irregular cornea physically bending the incoming light in a weird way.
Okay, so one eye is a local surface issue, both eyes is a systemic brain issue.
Spot on.
That makes total sense. Okay, now that we know what the sudden drop-everything emergencies sound like, we have to look at the slow burners.
The ones you see every day.
Right, the chronic conditions that are going to show up on almost every single NCLEX exam and routine clinical checkup.
In the clinical world, we call these the big three: glaucoma, macular degeneration, and cataracts.
Let's start with glaucoma, widely known as the silent thief of sight. First, we really need to lock down the numbers for you guys.
The numbers are crucial.
Normal intraocular pressure, the fluid pressure inside the eyeball, operates in a tight window.
Yeah.
10 to 21 millimeters of mercury.
Yes, 10 to 21.
If a patient hits a reading of 22 or higher, they have officially entered the danger zone.
And we are primarily talking about primary open-angle glaucoma here, which is by far the most common form.
Right.
It's insidious because there are 0 early warning signs. The elevated pressure slowly damages the optic nerve, creating patchy blind spots in the peripheral vision.
And if left unchecked, that peripheral darkness closes in until the patient is left with extreme tunnel vision.
Exactly. And the risk factors are a staple for any nursing exam.
Oh, definitely. You have to watch out for patients over 40 with a family history, uncontrolled diabetes, high blood pressure, or past eye trauma.
Right. And it's also crucial to note that African Americans are at a significantly increased risk for open-angle glaucoma, while East Asians and individuals who are severely farsighted have a higher structural risk for closed-angle glaucoma.
Good to know. Now, the standard clinical test for eye pressure is tonometry. It's that classic puff of air or a tiny probe tapping the cornea.
Yeah, tonometry.
But there's a massive clinical trap here. Tonometry cannot be the only metric used to screen for glaucoma.
It really can't.
Here's where it gets really interesting. If a patient can have glaucoma with totally normal eye pressure, aren't we giving people a false sense of security by just blowing a puff of air in their eye, getting a reading of like 15, and saying, hey, you're good to go?
What's fascinating here is how often medicine conflates the cause of a disease with the disease itself.
Oh, explain that.
Well, glaucoma at its core is a disease of the optic nerve. Elevated fluid pressure is just one mechanism, albeit the most common one, that crushes and kills that nerve.
So the fluid pressure is just the weapon, but the nerve is the actual victim.
Yes, and sometimes the weapon isn't pressure at all. You can have normal tension glaucoma where the optic nerve is highly sensitive and sustains permanent damage, even though the intraocular pressure never goes above that 21 threshold.
Wow, so that 10 to 21 range can still be dangerous for some people.
Exactly. That's why relying solely on a pressure number is dangerous. You have to physically look at the optic disc at the back of the eye, checking for a phenomenon called cupping.
Cupping.
Yeah, it's where the dying nerve fibers actually hollow out the center of the nerve. You must treat the nerve, not just the number.
Got it. Okay, so while glaucoma is busy stealing the edges of your vision, the next major condition operates in total reverse. Let's talk about the center of the visual field. Macular degeneration, or AMD.
Right, AMD.
This is the leading cause of vision loss in Americans over age 60.
AMD targets the macula, which is the tiny, highly pigmented central area of the retina responsible for our sharpest, most detailed vision.
So unlike glaucoma, AMD destroys your central vision.
Yes, you develop dark, blurry blind spots right in the middle of whatever you were trying to focus on.
And clinically, this is divided into two distinct pathways, dry and wet. Dry is the most common, where tiny protein deposits called drusen build up under the macula, slowly thinning and drawing out the tissue over years.
And that can unfortunately advance into the wet form.
Right. Wet AMD is characterized by neovascularization. The eye is starved for oxygen, so it frantically grows abnormal, fragile new blood vessels deep in the retina.
Yeah, and these weak vessels leak blood and lipids, creating massive swelling that rapidly destroys central vision.
It's just devastating.
It really is. And because wet AMD physically warps the structure of the retina with all that fluid and swelling, it distorts how the patient perceives shapes and lines in the real world.
Which perfectly explains the mechanics of the Amsler grid.
Yes, the Amsler grid.
It's this incredibly simple, low-tech screening tool. You post a grid of straight lines on a wall at eye level. The patient stands 12 to 14 feet away, covers one eye, and stares at a dot in the center of the grid.
Right, and if any of those straight lines look wavy, distorted, or completely blank, it physically reflects the warping of their macular tissue.
Wow.
If they see waves, they mark the chart and notify their physician immediately.
It is highly effective for early detection. And I know we also heavily emphasize dietary intervention to support that macular tissue.
Oh, absolutely. Nutrients like lutein and zeaxanthin, which are found in dark green leafy vegetables like kale and spinach, they literally act as internal sunglasses, absorbing damaging blue light before it hits the retina.
That is so cool.
Right. And zinc is crucial because it physically transports vitamin A from the liver to the retina to produce protective melanin. And omega-3 fatty acids are required to maintain the structural integrity of the photoreceptor cell membranes.
So basically, eat your greens, folks. It's literally structural support for your eyeballs.
Exactly.
Finally, the third of the big three, cataracts. This is the leading cause of blindness overall, but the good news is it's highly preventable, highly treatable, and develops very slowly, usually in clients over 65.
Right. A cataract is a clouding of the normally perfectly clear lens of the eye. Over decades of UV exposure and aging, the precisely arranged proteins inside the lens begin to denature. They break down and clump together.
And those clumps ruin the optics of the eye. Instead of light passing cleanly through the lens to focus on the retina, those clumped proteins scatter the light randomly.
Yeah, patients describe it as looking through a frosty or foggy window.
Colors look faded or washed out with yellow, right?
Yes, and that light scattering mechanism is exactly why cataracts are notoriously worse at night.
Oh, because of the glare.
Exactly. If a patient is suddenly complaining that they can't drive at night because oncoming headlights are blooming into massive, blinding halos, that is the clumped proteins scattering the light rays, you should immediately suspect cataracts.
Absolutely. Okay, so we have the diseases, the villains of the story. How do we mechanically screen for them on a routine Tuesday in the clinic?
Let's start with visual acuity. the classic eye
Oh
charts.
yeah, the Snellen chart for distance vision. And understanding the optical physics here actually helps it make sense.
It really does.
You stand exactly 20 feet away. Why 20 feet? Because at 20 feet, the light rays bouncing off the chart are traveling practically parallel to each other by the time they reach your eye.
Your eye's lens doesn't have to bend or flex at all to focus on them.
Right. It's a test of your absolute resting vision, known as optical infinity. That's why the top number in a vision fraction is always 20. It represents your baseline distance.
And the bottom number is the last full line the patient could successfully read. So a score of 20/40 means the patient has to stand at 20 feet to see clearly what a perfectly healthy eye can easily see from 40 feet away.
Got it. So higher bottom number means worse vision.
Exactly. That indicates myopia or impaired far vision, and a critical threshold for any nursing student to remember. 2200 or less is considered legally blind.
2200. Also a huge procedural note here. Patients must keep their glasses or contact lenses on during this test, unless they're exclusively reading glasses.
Very important.
You are testing their corrected vision, not their raw disability.
Correct. And for near vision, we switch tools entirely. We use the Jaeger chart, which is a small handheld card that must be kept exactly 14 inches from the patient's face.
And this is where watching the patient's body language is a diagnostic test in itself.
Oh, for sure.
If you hand a 50-year-old patient the Jaeger card at 14 inches, and they slowly start extending their arm, moving the card further away from their face to bring the text into focus, you just diagnosed presbyopia.
It's the absolute hallmark of aging eyes. Presbyopia is impaired near vision caused by decreased accommodation.
Decreased accommodation.
Yeah, as we age, that flexible lens inside the eye becomes rigid, like a stiff camera lens. The tiny ciliary muscles try to squeeze it to focus on the close-up text, but the lens just won't budge.
So they have to physically move the card further away to where the light rays require less bending.
Exactly.
Okay, so we've measured the sharp central vision with the charts. But since glaucoma taught us the periphery is often what dies first, how do you map the edges of someone's vision without bringing in a massive, expensive machine?
You use the confrontation test.
Right. You stand 2 feet away from the client, they cover their left eye, you cover your right eye, and you look directly at each other's uncovered eye. Then you bring a finger or a pen in from the periphery, up, down, left, right.
And the brilliance of this test is that the nurse is physically acting as the control group.
Yes, it's like a synchronized staring contest. Assuming your peripheral vision is completely normal, the patient should verbally confirm they see your finger enter their field of vision at the exact same split second you see it.
You are literally the human baseline for their blind spots.
It's remarkably elegant. Then we have the cardinal fields of gaze test, often called the H test.
The H test.
You hold an object about 12 inches away from the patient's face and move it smoothly in a clockwise H pattern, asking them to track it with just their eyes, without moving their head.
You are watching to ensure both eyes track symmetrically, looking for any shuddering or lagging, which is called nystagmus.
Nystagmus, okay.
And while it looks like you're just testing the small extraocular muscles around the eyeball, the H test is actually a direct window into the brainstem.
Really?
Yes. It evaluates 3 specific cranial nerves: cranial nerve third, the oculomotor nerve, cranial nerve, the trochlear nerve, and cranial nerve 6, the abducens nerve.
I love that concept. You think you're doing an eye exam, but secretly, you're conducting a neurological exam. The eye really is just an exposed extension of the central nervous system poking out of the skull.
It absolutely is. You are directly observing the brain at work.
Okay, we've mapped the retina and tested the cranial nerves, but before we finish, we have to pull back to the actual exterior of the eye. Eyelid trauma frequently trips up nursing students on exams, and we need to lock down the nitty-gritty anatomy.
But before we even touch an eyelid, we have to talk about infection control.
Oh, the golden, unbreakable rule of eye assessment. Always, always begin your palpation and physical assessment on the unaffected eye.
Yes, always.
If a patient comes in with a bright, red, gooey, swollen right eye, you do not touch it first. You assess the perfectly healthy left eye first, so you don't accidentally transmit a viral or bacterial infection from one eye to the other with your own gloves.
It seems obvious in theory, but, in the chaotic rush of clinical practice, it is a surprisingly easy mistake to make.
So what does this all mean for the specific eyelid conditions we need to memorize? Let's start with the classic showdown, the hordeolman versus the chalazion.
These two are constantly confused because they both cause lumps on the eyelid, but their mechanisms are entirely different.
Okay, break them down.
A hordeolum is just the medical term for a common stye.
Oh, a stye. So it's a localized infection of a tiny eyelash hair follicle right at the lash line. It's red, it's swollen, and it is acutely incredibly painful.
Right. A chalazion, on the other hand, involves the meibomian gland, which is a specialized sebaceous oil gland located much deeper inside the eyelid tissue.
Okay.
A chalazion causes extreme dramatic swelling of the entire lid, often way bigger and far more alarming looking than a standard sty, but with minimal pain.
This raises an important question.
Hmm.
Why does something that causes such massive, dramatic, whole lid swelling actually hurt less than a tiny little bump on an eyelash?
Yeah, that seems totally backward. A bigger infection should equal more pain, right?
It seems backward until you look at the microscopic anatomy. A hordeolum is an infection of a hair follicle. Hair follicles are tightly packed with highly sensitive superficial nerve endings designed to feel the absolute slightest brush of dust or wind.
Right.
When that tiny confined space gets infected and inflamed, the pressure on those superficial nerves causes acute, sharp, throbbing pain.
That makes sense.
But a chalazion involves the meibomian gland, which is buried deeper inside the dense tarsal plate cartilage of the eyelid. It creates a massive fluid and lipid buildup, but it's stretching cartilage, not compressing those hypersensitive surface nerves.
So you get extreme, alarming swelling, but a surprisingly moderate, dull pain response.
Exactly. It's all about real estate.
Mm.
A tiny infection in a high-rent, nerve-dense district hurts vastly more than a massive swelling in a low-rent cartilage district.
That is exactly how you should picture it.
Okay, the last piece of external anatomy we need to cover is the physical turning of the eyelids. Entropion versus ectropion.
Right. Entropion is when the lower eyelid structurally turns inward, rolling toward the eyeball itself.
And ectropion is the exact opposite. The eyelid turns outward, sagging away from the eyeball.
So what does this all mean when you're staring down a multiple choice question? The memorization trick is simple.
Yep.
N is for in, and X is for out.
Entropion goes in, ectropion goes out.
But in a clinical setting, what really matters is the mechanical danger each one presents.
Right, the danger.
If a patient has entropion, the lid rolls inward. That means their coarse, stiff eyelashes are now acting like a wire brush, constantly scraping and scratching against the incredibly delicate cornea with every single blink.
Ouch.
Yeah, that is a massive risk for a corneal abrasion, which can quickly turn into a blinding corneal ulcer.
So it is highly irritating and immediately dangerous to the structural integrity of the eye.
Definitely.
And ectropion, the lid sagging outward, presents a totally different mechanical failure. The lid falls away, exposing the pink inner conjunctiva to the open air.
The eye physically cannot retain its tear film.
Right. The tears just roll down the patient's cheek instead of washing over the cornea. The eye dries out completely, leading to severe chronic irritation and a high risk of bacterial infection because they've lost that protective, immune-rich moisture layer.
Exactly. Mechanics dictate the clinical risk. N for in, wire brush on the cornea. X for out, severe dry out.
All right, you made it. We have officially stared down the ocular assessment. You now have a high-yield, quirky, thoroughly mechanical mental cheat sheet for any eye question that gets thrown at you.
You know your pressures 10 to 21 is normal, 22 is danger.
You understand how the Amsler grid tracks the physical warping of macular degeneration.
And you know that a sun or shade coming down is a drop-everything hardware failure of the retina.
And most importantly, you know that an eye exam is never just about the eye. It is a direct window into the cranial nerves, the cardiovascular system, and the physical brain itself.
Absolutely.
Which actually brings me to a final provocative thought I want to leave you with.
Oh.
Something that builds on this idea of the eye acting as a raw data feed to the brain. We know how entirely manual these tests are right now. We're standing in clinics, waving pens and H patterns, holding up printed paper charts, and manually tracking responses.
Yeah, very manual.
But think about the technology we were all staring into for hours every single day.
Oh, this is a fascinating direction to take this.
Right. What if, in the very near future, the high-resolution front-facing cameras on our smartphones or the internal sensors in smart glasses could continuously track our pupillary responses and our cardinal fields of gaze in the background?
Entirely passively.
Yeah, entirely passively while we just scroll the news or read a text.
Continuous, passive neurological monitoring without a clinic visit. Wow.
Exactly. Imagine your phone catching a microscopic millisecond lag in your cranial nerve sixth, or noticing a sudden intermittent scotoma based purely on where your eyes are failing to track on the screen.
That's incredible to think about.
It could theoretically diagnose a microstroke or a dangerous rise in intracranial pressure days before you ever feel a single physical symptom. The ultimate drop-everything clinical alert delivered seamlessly by the phone in your pocket.
The eye is already functioning as a high-stakes brain scan. We just need the technology to automate the reading of it.
So next time you are staring deeply into someone's eyes, whether across a candlelit table looking for romance or across a brightly lit clinical exam room, remember, you aren't just looking at them. You are looking right at the machinery of their brain. Thanks for joining us on this deep dive. See you next time.